very good morning to everyone who's online and listening to Breakfast at UMHealth this morning. We are now coming to the second session. It gives me a great pleasure, and I'm very proud to introduce the next speaker from our department. Dr. Wei Lin is a lecturer at the Department of Biomedical Imaging, and she has been with us since 2018. She is completely in-house bred and nurtured, having done her MBBS and her Master of Radiology from University of Malaya. So she is currently pursuing her fellowship in interventional radiology, and in particular, her interests are in gynae imaging, in women's imaging. So she has been instrumental in being involved in gynae imaging. And her topic today, which is MR-guided focused ultrasound, is actually very special because we are actually the only center in the country offering this service. And she has been involved in this service for a while now. And that is why this is apt to be her topic. So I'm not going to take too much time, and without further ado, I will hand the floor, or the Zoom rather, to Dr. Wei Lin.
Thank you, Prof. Anushya, for your kind introduction. So today my topic will be about MR-guided focused ultrasound, or in short, MRgFUS. It is a non-surgical treatment of adenomyosis and leiomyoma. We know that uterine fibroids, also leiomyoma, is one of the most common benign tumors in women of the reproductive age, and their prevalence is age dependent, and they can be detected in up to 80% of women by the age of 50 years old. Fibroids are the leading indication for hysterectomy, which costs a lot of money, and also menorrhagia has significant economic implications for women in the workplace due to loss of productivity. Leiomyoma can be categorized into a few types: a subserosa, where they originate beneath the uterine serosa; intramural, where the fibroids are within the wall of the uterus; submucosal, where they originate from the myometrium and underlying the endometrium. They can cause excessive menstrual bleeding, dysmenorrhagia, and if it's large, it can cause pressure symptoms that causes bowel dysfunction, urinary frequency, urgency, back pain, and so on. It is also associated with infertility in patients in the reproductive age group. Adenomyosis symptoms are similar of those to fibroid and can occur in the same patient. It is not uncommon to find patients having fibroids concurrently having adenomyosis, up to 55% of patients. And it is diagnosed by identifying the junctional zone, which is more than 12 mm. So the treatment options for the patient varies from medical to surgical treatment. So our fellow O&G colleagues will perform the hysterectomy and myomectomy, and that is the more definite removal of the lesions, and patient can be eliminated of the symptoms and recurrence. Another minimally invasive therapy that our department does is a uterine artery embolization. This will devascularize the uterine artery. The symptoms can improve, and also patients will have short hospital stay as it's minimally invasive. Medical treatments such as GnRH, hormone therapy can help shrink the fibroid, and also can be used in adjunct to MRgFUS for large tumors to shrink the fibroid before proceeding for this treatment. So this is the spectrum of invasiveness. We can see MRgFUS is actually a non-invasive therapy compared to the rest. And the more invasive the therapy is, the more side effects. However, the treatment is more robust. So what are some of the advantages of MRgFUS? It is non-invasive, as I mentioned earlier. The patient does not have to have any surgery or any booking of any vessels. It can be done as an outpatient procedure. However, in our center, we usually admit for observation. It's fast recovery. The women generally return to activities within days. Quality of life of most patients are relieved within the weeks following treatment. It is safe with minimal side effects as no drugs are given besides the mild local anesthesia. It is uterine sparing and maintains natural hormone function and may be considered in patients who seek fertility sparing options. So for this treatment, as all treatments for fibroid and adenomyosis, is very customized because it depends on the size of the lesion, the symptoms, the age of the patient, the location, and also if patient is seeking to have kids. So in MRgFUS, we usually treat patients who have uterine fibroids of less than 18 week size, no more than 3. The lesions must not be intracavitary or pedunculated, and we also treat adenomyosis. The absolute contraindication includes patients who are pregnant, the uterine lesions which are suspicious of malignancy, pelvic infection. Relative contraindication includes multiple scars as they may experience pain at the scar site, and lesions that are not safely accessible by ultrasound beam. So these are 2 examples of leiomyoma that are suitable for this treatment. This patient here, we can see that the lesion is located at the submucosal region, and this patient actually had symptoms of bleeding. On the right, the patient has an intramural fibroid, and this patient complained more of pressure symptoms, which is because it's compressing on the bladder wall. And from this location, we can see that it's quite accessible for MRgFUS as there's no bowel anteriorly that is causing obstruction. So we look at this MRgFUS, MR guided focus ultrasound. So we use 2 imaging. One is MRI. MRI is very good for soft tissue definition, and it also gives us real-time thermal mapping of the system. During the procedure, there is feedback on tissue temperature during the treatment, and that's why it's very safe. The ultrasound part of this treatment is a focused ultrasound beam, which is used to ablate the specific tissue. So this is how the ultrasound beam works. So similar to how a magnifying glass focuses light energy, the ultrasound is focused on the specific point, in this case, the fibroid. So on this side would be the patient, will be the machine where the transducer lies, and it emits ultrasound waves, and it converges at the highest energy at the focus point. The nearer the beam is, the higher the energy is. It can burn up to 56 degrees Celsius for up to 1 to 3 seconds. And the target cells heats up and get destroyed. And this is ablation. Why do we need MR guidance? This is because there are multiple very vital crucial structures that we need to avoid, such as the bowel, the nerves, the skin, and if there's any surgical clips, we need to avoid. This can be prevented by demarcating the landmarks during the pre-planning MRI. So as mentioned earlier, the MR thermometry provides us real-time feedback during the treatment, showing regions that have met the thermal dose requirements. And each sonification lasts about 20 to 30 seconds and followed by cooling period of 30 to 90 seconds. So this is how the equipment looks like. This is the transducer where it's connected to the cable. Patient will be in prone position, and there will be a gel pad to conduct the waves. And the target is at this area, the fibroid, and the MR pelvic coil is strapped around the patient to obtain the images. And this is a special customized system. Patient will be inside the gantry and given adequate analgesia. in our center, we give supplementary Uterine, IV paracetamol 1 gram, IV midazolam, betadine titrating doses. Also, we prep patient with a urine catheter and rectal tube. This is for manipulation of the uterus if needed. While in the gantry, the patient's vital signs is monitored and patient is given an emergency button to press if the pain is unbearable. First, we have to perform a calibration, and this calibration provides the system with information and correlates patient's position. We can scan we will plan the procedure after we do the calibration. You can see this is the transducer template, and this is the fibroid, and this needs to be aligned with the lesion that we are ablating. Next, we draw the region of treatment. We need to avoid the serosal surface, so we need at least a 1 cm gap in between the region of treatment and the serosal layer, or not it will burn and cause patient severe pain. We also draw low energy density region lines which reduce the heat towards the important structures such as the sacrum, the bowel, the pubic bone, and also the skin. Next, the machine will plan. So once we draw the region of therapy, the software will calculate the number of ablation zone, which is also the number of sonification. So the larger the lesion, more sonifications are needed to ablate the lesions. So this is halfway through a treatment. We can see that this is a focus spot, as we call it, and these are the beams. So the most energy, most heat will be directed at this focus spot, and away from this focus spot will be less heat. Okay. So this area where there is a blue line are areas of post-ablation. You can see there are some cystic lesions that do not take any heat. So these lesions are not able to be ablated. So as mentioned earlier, bowel should not be present in the beam path. So for example, this image on the left, we can see a lot of bowels. So we cannot proceed with the ablation unless we manipulate it. So we can infuse rectal contrast to push the uterus down and put in a CBD to release all the bladder so the uterus can fall to the front. However, you can see here that still some bowel inferiorly. That means that this ablation has limited access. Probably only certain parts of the fibroids can be ablated. So this we need to counsel patient that depending on the location on the day of the procedure, you may not have a complete ablation zone. Also, we need to refrain from other obstacles like IUCD, surgical clips, and surgical scars. However, the machine can also be angulated and avoid the areas that we need to avoid, such as a surgical scar. Another accessibility is that another setback is the lesions that is 12 cm from the skin is the maximum effective focal distance of the system. Meaning if the lesion is too deep and posterior, we may not be able to ablate the lesion. So again, we need to counsel and also find a suitable patient for this procedure. Viability of the fibroid. As we know, there are different types of fibroids, different patterns of fibroids which can be enhancing, partially enhancing, and enhancing. So lesions that are not enhancing are not viable, meaning they are not vascular. So there are no treatment benefits if we proceed with this. Some of the fibroids show hypo and some show hyperintensity on T2 images. So if there are these bright fibroids with a bright high signal on T2, they are less susceptible to the treatment. Also, the number and size of the fibroids. If there are too many, we will spend the whole day burning and it still will not be fully ablated. So we limit to not more than 3 lesions, and the total fibroid load should be less than 500 cc per treatment. As mentioned earlier, intracavitary and pedunculated lesions are one of the few contraindications. We do not treat pedunculated fibroids, as if it's ablated, it may fall off the neck and may detach into the abdominal cavity. And then the surgeons will need to go in and remove this. So this is a large fibroid that is extending superiorly and is very close to the lumbar spine. So this lesion cannot be treated safely, and we need to manipulate, which is to remove urine from the bladder and put in some rectal contrast to create a space between the fibroid and the lumbar spine. If not, there will be injury to the lumbosacral plexus. This is another example of how we use rectal filling to displace the uterus away from the sacrum. So this patient has a posterior fibroid, and you can see it's very near the lumbosacral region. So what we can do is to inflate this rectum with gel, and also we can insert CBD to reduce the urine, and so the uterus can fall anteriorly. So why is MR guidance and control important? Okay, we're talking about precise visualization of the tumor, so we can avoid other organs and the beam path to target the exact lesion and make sure there's no unwanted structures or organs in the beam path. So also we have real-time thermometry that measures the temperature, so we are very safe in doing what we are doing. And immediately post-treatment, we can give contrast to measure the precise, to validate our treatment. So these are a few examples of cases that we have ablated. On the left, this is a T2 weighted image or sagittal image before the treatment. Patient had symptoms of heavy bleeding and cramps. So this is a post-ablated image. Post-contrast, we can see a very nice homogeneous burn area. And after 3 years, the fibroid actually shrank more. Another patient with multiple fibroid. So this is the birth case was a single fibroid. Below case, we can see there are 2 fibroids and a 2 nicely burned area that is seen post-treatment with contrast enhancement. So these are features of post-ablated fibroids. This is an example of adenomyosis, a posterior wall adenomyosis, where you can see post-burn area is nice and homogeneously. This is another example of how we may not be able to target all the fibroids in the uterus. As mentioned earlier, there is a maximum length of 12 cm. So this posteriorly located fibroid is unaccessible, thus we have to forego this lesion. However, the other lesions are well ablated, as you can see in the post-contrast imaging, a nice homogeneous T1 weighted image. So FRGFUS is not a new treatment. It's actually been approved by the FDA since 2004. And in UMMC, we have been using it since the year 2010. There are multiple long-term follow-up studies, fertility studies, and GnRH studies before treatment of MRgFUS, and all these findings are very, very promising. So in many articles, they all show similar findings where it shows significantly improvement of clinical symptoms in up to 80% of women with uterine leiomyoma. It is safe and effective treatment of symptomatic uterine fibroids. And also previous studies were more to treatment of uterine leiomyoma, and recent studies of adenomyosis also shows very good results. So this GnRH is used as an adjunct to inhibit cellular proliferation and induce apoptosis, and it shows very promising results when used concurrently with MRgFUS. For fertility, it is also, this study was comparing patients, 93 patients of adenomyosis, some treated with this HIFU. HIFU is also known, MRgFUS is also known as HIFU, and 43 patients underwent laparoscopic excision. So this is a comparison of a surgical treatment with a non-invasive treatment. And it shows safe, effective therapeutic management, and HIFU treatment achieve better post-operative reproductive outcomes. There are many more articles showing the benefits of MRgFUS with symptomatic fibroids. There was a short retrospective study done by one of our students previously. She went through the patients with uterine adenomyosis which undergo this MRgFUS. The uterine volume pre-ablation, 6 months post-ablation, and 12 months post-ablation were looked into together with the lesion size. And also patients were asked about their satisfaction of symptoms post-treatment. So all 8 patients, they tolerated this procedure very well, no adverse reaction reported. There were no additional treatment or blood transfusion needed, and reduction of overall uterine and lesion volume in 6 months. And clinical symptoms improved overall. So this is another example of how adenomyosis can be treated. This shows a posterior wall focal adenomyosis, and immediately post-treatment we can see a nice ablation zone. Other uses of MRgFUS includes bone metastasis, prostate, breast, and also brain for treatment of essential tremors and Parkinson's disease. However, we don't have these services in our center yet. I would like to thank our MRgFUS team in PPUM and also my mentor, Prof. Anushya, who has guided me in this journey. Thank you very much.
Thank you very much, Wei Lin. That was a very good overview of what we actually do, and which is MRgFUS. There are a few questions from the floor. The first question is to Dr. Wei Lin is, what is the total cost of MRgFUS? And in your experience, how many sessions does a patient need if she has roughly a 16-week size uterine fibroid?
So in PPUM, we have to pay for the gel pad, which costs about 4,000 ringgit. So the whole, including the consumable, it may go up to 5,000 to 6,000. And how many sessions also depends on the response of the fibroid. As mentioned earlier, the more dark fibroids are more receptive towards this treatment. The ones that are more bright are less receptive. So depending on the type of how the intensity of the fibroid on MRI.
Yeah, there's another question. We have a lot of questions coming in. Okay, what symptoms would the patient complain as the body gets rid of the destroyed tumor tissue?
So the patient may complain of menstrual cramps, however, it will not be long, maybe just a few days.
I would also, would like to add that usually we do tell our patients as the fibroid or adeno is dying, and it takes a while. It takes usually up to 6 months. They may have a little bit of discharge, but that's about it. They don't really have much symptoms in terms of when the body is getting rid of destroyed tumor tissue. Okay, so we have another question. Assuming the selection criteria are followed, how effective is this in reducing symptoms when the volume reduction is not complete? And is there a maximum number of treatments per patient?
We will reassess in 6 months with MRI post-treatment, and if the volume reduction is not complete, we could try again. And I don't think there's a maximum number of treatments, but also we wouldn't go more than 2 to 3 times, I think. So far, I think we only have 2, maximum 2 times, and then we may consider other treatment like adjunct uterine artery embolization.
Yeah, just to add to that, most of our patients find that their symptoms, so we don't treat a fibroid that's not symptomatic or adenomyosis that's not symptomatic. We treat them only if they're symptomatic. So we're basically treating the symptoms. And most of them, especially if they present with menorrhagia, they will immediately tell us that their symptoms have relieved. And so we do have a large cohort of patients, and I'm sure my gynae colleagues will agree, who are not actually ideal patients for surgery. And so therefore, this is a very good treatment option for them. In terms of how does this compare with surgery, there are lots of papers out there. Are there any other questions? Okay, I think if there are no more questions, thank you very much, Dr. Wei Lin. And we will end this session this morning. Jaya, anything from your end?
No, I just want to thank Dr. Sams and thank you to the organizers of PF at UMHealth.
Okay, thank you very much, everyone. Have a good day.
Thank you. Bye.